Hi, in this tutorial, let's talk about contraction of the heart. Now, the contraction of the heart is both an electrical as well as a mechanical event. The action potential that occurs at the cell membrane is what begins the contraction of the heart. It would set in motion a series of events that would eventually lead to heart's contraction. Sarcomere is the basic unit of mechanical contraction. It is lined by the Z line, and in between those Z lines are the thick and the thin filaments, namely myosin and actin. As these two filaments slide over each other, that leads to shortening of the sarcomere. At the microscopic level, this is where the systole begins, eventually leading to contraction of the entire cardiac chamber. ATP that is available in the cell provides energy for this contraction. But for this process to take place, myosin heads should interact with active sites on the double helix actin filaments. These active sites are guarded by complex structures known as troponins. Unless something displaces this troponin from actin filaments, it will not be possible for actin and myosin to interact. In other words, contraction of the heart cannot occur without troponins being displaced. And what is it that would displace these troponins? The answer is calcium. We need calcium to kickstart the systole of the heart. Remember, ATP is always present in the myocyte, but it is this calcium that is alternatingly presented to and taken away from the myocyte. That leads to the cyclical systole and diastole as we know of the heart. Think of it this way, that whenever calcium is available, my heart will contract, and whenever calcium is taken away, my heart will have to relax. And it is this cyclical presence of calcium that the electrical activity of depolarization and repolarization of the heart controls. We know that during the plateau phase of action potential, calcium does enter into the cell. However, this small amount of calcium coming from the extracellular space is not sufficient to bring about contraction of the heart. But this calcium does interact with something else. There is a huge reservoir of calcium in the intracellular space known as sarcoplasmic reticulum, and it has a receptor known as the ryanodin receptor. The ryanodin receptor responds to the extracellular calcium and can also be influenced by sympathetic activity. When the extracellular calcium interacts with ryanodin receptor, it leads to a massive release of calcium from the sarcoplasmic reticulum, a process known as calcium-induced calcium release, or in more interesting terms as calcium spark. It is this calcium spark that is responsible for kickstarting the contraction of the heart. As this calcium reaches the actin filaments, it displaces troponins, exposes active sites to interact with myosin heads. In the presence of ATP, myosin heads attach to actin and give rise to power stroke to bring about shortening of the sarcomere. More is the calcium available, stronger will be the contraction. But the heart has to relax in order to receive blood. That means calcium should be sent away. Remember that the SR has huge store of calcium already, and so sending back calcium into SR needs an ATPase pump. This role is played by SERCA. SERCA then is equally important for heart's contractility. Now, let's understand how these physiologic features would change when the heart begins to fail. As the heart fails, its stroke volume will fall. As the stroke volume falls, that would stimulate the sympathetic system. We know that sympathetic system can increase heart's contractility. But what consequences would the sympathetic system have at the cellular level? Role of sympathetic system is time dependent. In the initial stages, sympathetic system increases the calcium release from the sarcoplasmic reticulum via its action on the ryanodin receptor. As the calcium spark increases, heart contracts stronger, and the sympathetic stroke volume can be restored back to normal. That means in the early stages, activation of the sympathetic system is beneficial for the heart and improves heart failure. But this sympathetic system, if it is continuously activated over a long time of months or years, that would mean the calcium spark is always overworking. Eventually that means concentration of calcium in the ICF is gradually going to rise. Think about it. Calcium spark by itself is a passive process of diffusion, which means it is dependent on the calcium concentration gradient between sarcoplasmic reticulum and intracellular fluid. If intracellular fluid concentration of calcium rises, what will happen to the intensity of the calcium spark then? Well, when this chronic stage sets in, efficacy of calcium spark will be dampened, and then my heart's contractility will again suffer. Such changes happening in the structure and function of the heart in chronic heart failure are known as remodeling. Remodeling will aggravate heart failure whenever it sets in. It is important to understand that remodeling is a result of overuse of compensatory mechanisms. Timely intervention can reduce the impact of such remodeling on the heart. To summarize, we know that the contraction of the heart is an electrical as well as a mechanical event, and that the connecting link between these two is calcium. Sarcoplasmic reticulum is the source of calcium for muscles contraction, and it is available via the calcium spark. This calcium is responsible for the actin-myosin interactions, and in the presence of ATP, heart will contract, and this is known as the sliding model of contraction. We have also seen how sympathetic system is responsible for enhancing the contractility via the ryanodine receptor and calcium release. This is helpful for a failing heart in acute stages, but it can worsen heart failure in long-standing cases, a process known as remodeling. Thank you. If you have any questions on this topic, feel free to discuss with me during our lectures or on your Quest app. Jai Hind.